All right, let's do a little visual diagnosis. The first case is on page 295. So this is a 48-year-old patient. Comes to ED with a little lightheadedness and palpitations, no chest pain, is only modestly short of breath. Notes that he's had several similar episodes in the past, but they were resolved after a few minutes. But now this one is persisting. He has no other cardiac history, but only rarely sees a doc and only when he's sick. Dave, is this working? Yeah. Okay. So what are your thoughts about that EKG? Anybody? Primary rhythm, what that rhythm look like? I mean, it's no trick question. It's kind of like, what do you think? So it's AFib. Yeah. Anybody want to make any comment about this AFib? Is this atypical in any way, or basically garden variety AFib? 295. Yeah, it is very fast. Exactly. That's the point. Normally AFib is in the neighborhood of 150, 200, maybe max kind of thing. And if you notice in this case, there are some runs where this guy's going at 300. So this is not typical of AFib. So any suggestions as to what may be going on here? So this is the WBW AFib. This is the one that you got to really be looking for, because traditional treatment for this, at least with drugs, can be you can make this person worse and have this thing deteriorate, accelerate and deteriorate into VFib. So the question then is, of those drugs down there, which one, if you were going to use a drug, which one would you choose of the 4 drugs that are listed there? Yeah, that's one of these drugs from the past that kind of rarely gets used, but this is a case where you would use that drug, and the other drugs would not be used. They would actively not be used because they basically differentially slow the conduction through the AV node, leaving the accessory node to be able to pick up these impulses and pass them on and accelerate the rhythm. So those drugs which traditionally would be viewed as rate slowers, in this case, could be a rate accelerator. So this is AFib with WPW. The idea is procainamide, and I guess if it got nasty enough, you have the option for using electricity. Now the Canadians in the bunch, and I think probably the Aussies and the New Zealanders, have a fairly aggressive approach to atrial fibrillation in the emergency department. What do you Canadians do? You cardiovert them. I mean, it's kind of like routine that happens. It's not the exception. And you give them chemicals or drugs or electricity. Most of the time, electricity. How many of you in the United States basically routinely are trying to convert new onset AFib? So it's a few hands, but bottom line is that this has not been our tradition. This has been the tradition, and the Canadians have been very aggressive about this, and they teach us about it. How about New Zealand, and you guys shocking them down there? You're kind of Canadians, aren't you? You're kind of in the realm. Yeah. You give them drugs to slow them down. You don't really try to convert them. Okay, so one of my friends, basically, Al Sacchetti, maybe some of you have heard of Al. He participates on MRAP. Basically, is very aggressive, and has adopted the Canadian policy that if you're recent onset and you don't have any, he meets a certain number of criteria, they'll convert you in the emergency department. And they looked at all of the patients that they saw over a couple of years. That this article was just accepted, and is e-published, but not in paper yet. And basically what they found was that they were successful. They sent a lot of people home right out of the emergency departments. Some of them got drugs. Some of them converted on their own. Some of them basically came in very slow AFib, 88 rate. It was the average. They sent those out with pretty much nothing. and they shocked another subset. So the idea is that the goal was to get these patients back to sinus rhythm rather than just trying to slow the rhythm on the way out. Because I don't know if you've ever had AFib. It's not pleasant to have your heart beating irregularly. You can be very much aware of it. And so the idea of being in normal sinus is a good thing. One of the unintended consequences of their taking this position is that the number of patients they admitted to the hospital was relatively small compared to the totality that they saw. And the number of patients they admitted to the hospital, not only were they small, but they were also the sicker patients. So when they were, were looked at in terms of the quality of the care that they provided atrial fibrillation patients on the inpatient basis, they didn't do very well because the patients that were selected out that normally we would have admitted all of them. They only admitted a subset. And so instead of getting a pat on the head, they were kind of given a little scolding because they weren't doing so good, not recognizing that there was a clear-cut case of selection bias here when these patients were looked at because they were not the way other patients are in the U.S. hospitals, where we are not as aggressive as the Canadians are or have been with regards to converting these rhythms. Is there any movement at the hospital that you're at to move in this direction? Those of you who do it now, I mean, is this a recent phenomenon? Well, yeah, and the longer they fibrillate, the more at risk they are for clots, and the more of a project it is, because there's kind of an arbitrary dividing line at 48 hours. If you've been fibrillating for 48 hours or more, that they won't cardiovert you until they do a transesophageal echocardiogram to see if you have a clot. They make a big project out of it. So actually, the clock is running in these cases, and the sooner, the better. Even though the literature on, well, is it 48 hours or not, there's no studies on that kind of thing, but that's kind of the arbitrary line. And some people are more aggressive and they say, well, we're going to do this transthoracic echocardiogram or transesophageal with less than that. And the yield is really, really low. But the fact is, you have to be sedated to have that thing done. It's a pain in the butt. So one other question then. What is it going to take for us in the States to kind of start moving to what the Canadians have done? Do we want to do this, or we just want to just admit them? Because the States people in Canada, the majority of the patients who come in AFib go home from the ER. The majority. The only problem with that is that if this is paroxysmal atrial fibrillation, the longer they stay in it, basically, the more. And then there's this issue about anticoagulating them, and all. A significant number will. But the others can be actively cardioverted by amiodarone, butylide, electricity, those kinds of things. Let's look at case number 2. This is a 35-year-old woman presenting with a 3-day history of a sore throat, painful swelling in the right side of the neck, fever, rigor, hemoptysis, dyspnea. Exam revealed pustular exudates on the right tonsil. So what are the findings that noted in these pictures? Anybody? This is a great machine because it comes with the arrows right on the picture when they develop it. That is supposedly, those arrows are pointing to a thrombosed internal jugular vein. And that thrombosis was caused by an infection. And that infection was caused by generally a peritonsillar abscess. Peritonsillar abscesses are generally group A, beta hemolytic strep. But sometimes they become secondarily infected by this nasty bug, Fusobacterium necrophorum, which is a gram-negative anaerobe. As soon as you say the word anaerobe equals pus. Pus formers are the anaerobes. And so this peritonsillar abscess caused by association this thrombophlebitis of the internal jugular vein, which is then these bacterial-seeded clots are then going into the lung and making those, see those white arrows there? Those are abscesses in the lung. And this entity is called Lemierre syndrome, and it's supposedly, very rare kind of thing, and it would be kind of unusual for you to see this. But the fact of the matter is that for one of a number of reasons, this thing is increasing in frequency. Have any of you seen this diagnosis at all? 1, 2, and 3, 4? Okay, I saw one, 5. And it's typical. Person is quite sick, high fever, sweating kind of thing, pain on one side of the neck. You look into the throat, they have an infection going on there. You take the chest x-ray and you see areas of infiltrate as a result of these septic emboli that are going through the lung there. So this is one source of infection that may require aggressive antibiotics, that's for sure. The antibiotics that we think about when we talk about, it's going up and down a little, Dave. The antibiotics that we think about whenever we talk about an anaerobe, what are the antibiotics that come to mind automatically? Anaerobe, we get 2 of them, clindamycin and flagyl, right. And typically when people talk about like dental infections, they say, well, give them penicillin. The vast majority of dental infections have anaerobes involved too, so the idea of adding some clindamycin or flagyl in patients who have dental infections is considered to be a reasonable idea. Let's see if there's anything else interesting here. Oh yeah, Dr. Center, you know the Center criteria for a sore throat kind of thing? Where you have 4 points, basically you have no cough or URI symptoms, you have exudates, adenopathy, fever, and then there's the Mike Isaac addition. Under age 15, you get an extra point. Over the age of 45, you lose a point because strep is not really over 45 doesn't occur, more common under 15. He said 80% of people he thinks who have a grade 3 or 4 on the Center scale, he says that they have probably a bacterial infection, either group A hemolytic strep, group C hemolytic strep, or this bug. And it's one of those things where we only have one infection in the body where we treat it if it's only caused by group A hemolytic strep, but we don't care about what else is causing a throat infection. And that's kind of really weird. We don't take that approach when we have a bladder infection. We'll kill any bug that's causing that bladder infection. We just don't say, well, we're only going to go for E. coli. That's the only pathogen that we're talking about here. So the idea here is that conceptually, there may be some other bugs that are causing sore throats that may be amenable to antibiotic therapy. We got mycoplasma. We have there's a great study actually where they took people's sore throats, they cultured them. If they did not have strep on culture, they gave them azithromycin. And those patients who got azithromycin did better than those patients who did not, implying that there may be some other bacteria that are causing a sore throat that may be amenable to antibiotic therapy. All right, let's move on. Any questions, comments, disagreements? Number 3. 7-year-old female presents with lower abdominal pain for 2 days, has a background of hypertension, ischemic heart disease, and atrial fibrillation. Exam reveals tachycardia and pallor. On abdominal exam, there are tenderness and rigidity in the lower abdomen with signs of peritonitis. Anybody want to comment about what findings are noted on the CT exam here? Anybody? Yeah, see all those little bubbles around there? Those little air bubbles, those are in the bowel wall. So this is kind of not not good. This is consistent with, they call that pneumatosis intestinalis. There's generally considered to be a late finding of an ischemic process. This lady does have atrial fibrillation, could throw a clot clearly too into her visceral organs. What kind of contrast would you be using in this study if you think that this is the etiology? IV, oral? The answer is neither. And this you can see there's no contrast in this, and these air in the abdomen shows up as black, pretty straightforward kind of thing. There's a lot of causes for this other than just ischemic bowel. In fact, other things that can cause air to leak out of the lung, like in some of the COPDers have been shown to have that air track down and go along the mesenterics and get into and show up like this. What would if we were to do some chemistries in this person and the phosphate was, we found the elevated phosphate, what would that be indicative of in this situation here? Phosphate's high. Dead gut, exactly. This is a late finding. The phosphate is generally intracellular, and when you have it elevated, it means that you are way down the path here. And there are a couple of other conditions that we don't necessarily have to get into here that may cause that. Number 4 is a 75-year-old. Altered level of consciousness for 8 hours. Family notes vomiting and headache in the hours prior to the development of his loss of consciousness. Multiple family members have had the flu recently. Recent labs are normal, routine. Neurologic exam is non-focal with depressed level of consciousness. Blood gases are normal. It would be kind of unusual for, I think, any of us to know what these CT scan findings are consistent of. But if I told you about somebody who had nausea, vomiting, altered consciousness, and a number of the members of the family are also sick with a flu-like illness, that is kind of the biz-buzz of what? Carbon monoxide. So this is a carbon monoxide case. What test would make the case diagnosis? So carboxyhemoglobin, we would do that. What's seasoned in it? Well, the implication is they're cooking with their hibachi indoors or something like that, or a leaky heater or something. And this CT basically shows a number of physical findings that are unique to carbon monoxide poisoning that occurs in the brain with those arrows there. The pathophysiology of this process. Well, what would you expect the blood gases to be in this case? This is one of the questions they typically ask on the boards. Blood gases should be perfectly normal, because this has not got to do with this gas screwing up the dissolved gases in the bloodstream, but it's really about this gas attacking hemoglobin and preferentially attaching to it and not letting oxygen attach to hemoglobin. So basically, it's this affinity for oxygen. So it's not really truly a gas problem. It's a problem of hemoglobin has been compromised substantially here. So I guess the idea here is you put these people in a hyperbaric chamber to try to get more oxygen to help convert this problem and push that carbon monoxide off of there, and then you would ask the question, does that work? And I got a couple of papers here that might challenge that. They're in your manual too. The first one is really a 2011 paper about the treatment of carbon monoxide using my watch broke. Using hyperbaric oxygen, because one of the questions that we have is, well, we got this case, do we have to start transporting this person to somewhere where there's a chamber? Is that going to be expected of us? Is that going to make them better? If we don't do that, are there going to be some consequences? This is a French study, 2 prospective randomized trials in one paper. What they did, 179 non-comatose patients, age 15 or older, were after isolated domestic carbon monoxide poisoning with only a transient loss of consciousness, were randomized to 6 hours of normal baric oxygen or to some formula of hyperbaric oxygen. So those people had a transient loss of consciousness. Then they had another 206 who were comatose. These were really bad. And they did something similar. They randomized them to 4 hours of normal baric oxygen plus 1 hyperbaric treatment versus more hyperbaric treatments. And the results, in the non-comatose subset, there was no significant differences between the normal baric and hyperbaric oxygen groups in the rates of complete recovery. Complete recovery was 61% in the normal baric oxygen group and 58% in the hyperbaric oxygen group. Rates of delayed neurologic sequelae, which is really one of the problems in carbon monoxide, is they have these ongoing neurologic problems. 1 month after exposure, rates were 35% in each group, so hyperbaric didn't help them. And the rates of persistent neurologic exposure beyond that were 4% and 6%. So in the subset of people who were just non-comatose, they didn't do well. They didn't do any better. What about in the comatose patients? The comatose patients, 150 were available for 1 month follow-up. Complete recovery was significantly less frequent in the group treated with hyperbaric oxygen sessions. 47% versus 68%. Big difference, big difference. Rates of delayed neurologic sequelae, 32% with hyperbaric, 28% without. Persistent neurologic sequelae, long-standing, 21% versus 5%. So this study was terminated early because it was looking like clearly these people were being harmed by hyperbaric oxygen, the comatose patients. And was that the only one? No. Well, there's another one here. This was in the Annals of Emergency Medicine. It's a review of 6 randomized controlled trials of hyperbaric oxygen. 4 of the 6 studies did not find hyperbaric oxygen to be useful. In a pooled analysis, there was no statistically significant difference between the outcomes achieved with hyperbaric and normal baric oxygen. All of the trials exhibited flaws in design and analysis. Caution that these findings should be interpreted, therefore, with some caution. Studies conducted to date do not provide evidence that hyperbaric oxygen therapy decreases the occurrence of adverse neurologic sequelae in patients with acute carbon monoxide poisoning. There are some Australian studies that have also shown the same thing. So I'll stop here on this one.